My name is Haley Childers. I'm from Southwest Baptist University, and this presentation is going to be covering preventing surgical site infections. Surgical site infections are important to me because as a circulating nurse in the OR, one of the main duties is to clean the site before surgery begins. And as a nurse in the OR, I want to be able to provide the most care to the patient and not provide any harm. Why this is important to the public is because 2 to 5% of all surgeries result with a surgical site infection, and that is from Loyola University Health System. Also, this is important to healthcare systems because surgical site infections cost $3.5 to $10 billion per year, once again cited from the Loyola University Health System. And lastly, this is important to patients because surgical site infections add an average of 9.7 extra days in a hospital stay on top of their current hospital stay, which can add up pretty quickly. So my PCOT statement, this was easy to form due to I wanted my surgical patients to be the population. The intervention would be ChlorPrep. Then my comparison is betadine. The outcome would be to reduce the number of surgical site infections, and the time would be over a year. So it reads as, for surgical patients, does ChlorPrep used before surgery compared to betadine reduce the number of surgical site infections over a year-long program? With this, I chose a year due to the fact that I wanted to be able to have enough patients over the time to be able to produce enough information to have a really good sounding choice over which prep would be best. When I was searching for this evidence, I first started with Cochrane. The terms I searched were ChlorPrep reducing surgical site infection. When I first searched for that, I got 9,584 results. From there, I added filters such as Cochrane Evidence Review and Cochrane Nursing Care. From there, I lowered it from 9,584 to 671. And then also I used the Clinical Complete search, and in that I was able to search ChlorPrep and reducing infections and surgical site infections. From there, I got 16 searches. Then I reduced it by using the filters such as the year. I used it, limited to within 10 years of the current year, and also did the geography. I made sure it was only in the United States. That pushed me down from 16 to 9. And from there, I just kept looking to make sure that the content of the research articles fit the content of what I was searching. From the feedback I got on my assignment, it showed that I should not have used the term ChlorPrep, which was the brand name. Instead, I could have used such words as skin prep or patient education, which would have helped me to have more specific information and not necessarily just for ChlorPrep. Within my 5 articles that I found, some of the similarities were the inclusion and exclusion criteria. All 5 of them had to be adults from 18 and older. None could be pediatric. And then the number of patients. There were 3 out of 5 studies that had over 1,000 patients being used. Gahobriel used 6,959 patients, spinal patients. Majej used 2,985 cardiac patients, and Swenson used 3,209 general surgery patients. Also, the number of days that they monitored post-surgery for the surgical site infection, the Most of them were at least 30 days after. That was the minimum that each study kept further monitoring for a surgical site infection. Also, the cleaning solutions. All 5 of them used ChlorPrep as one of the comparison for the study. Some inconsistencies within all 5 of these articles. The results of each prep solution used, in all of them, they all used the chlorhexidine gluconate, which is the ChlorPrep. However, they also each had different variations of what they were testing it against. They're either using betadine, isopropyl alcohol, or iodine paint and scrub, and each one was using different variations of that. With that, they each came out with different results as to which one was most effective, or if that both of them in fact were the same. Also, the types of surgeries that they were all used on. Savage used elective lumbar surgery. Saltzman used it on soldier surgery. Gabriel used it on spinal patients. Majed used it on cardiac patients. And then Swinson used it on general surgery patients. Each of these, all different, elaborate, and even within each of the study, there were different types of surgeries, the in-depth and the different amount of time of surgeries for each one. Lastly, there were different designs of the study. Some of them had multiple surgery sites. There was multiple ways of collecting the data, such as Majad used 2 facilities with 2 different staffs to apply the prep solutions. Savage randomly selected prep cultures taken before, during, and before closing of each surgery to test whether or not each solution was effectively cleaning the site. Swinson used 3 solutions for 6 months, and he blocked off each time period. There were 2 months out of the 6-month period where he would use a different cleaning solution in all the general surgeries. Saltzman randomly prepped one of 3 solutions for all of his shoulder patients. However, only the first 20 patients out of the 150 got before cultures of the site, and then the rest of the population had only cultures afterwards, showing how much bacteria was on the site. Some gaps within the study. All the studies did not verify the application process of the prep solution. Then turnover of the operation room was not taken into consideration. That's what Gohoriel mentioned in his 2017 study. Also, there were 2 locations with separate staff that are used for the study, as mentioned with Majed in 2016 study. Swinson, with his 2009 on the general surgery, had different types of general surgery, which all take into play the time, blood loss, as well as the invasiveness of the surgery. Another limitation was that Savage noticed that the blood loss, surgery time, and BMI of patient were not taken into consideration of his trial, which could have altered the results. And lastly, Gahobriel mentioned that since they did not have a blind or randomized study, that those also could have affected the results. In conclusion, all the different solutions proved more effective with different surgical sites. As mentioned, the different types of surgery and different surgery sites, it all altered the results and proved that some of them proved that ChlorPrep was not most effective, others proved that betadine was more effective. And with that, it does not make any kind of implications that one should be used more so than others in all over surgery. The guidelines provide instructions for proper use of each solution. They do not have a guideline that specifically states that one solution should be used for surgical sites compared to others. And I believe that to be a good guideline as the fact that none of them proved to be superior than the others.